You have a patient with high airway pressures. You have to make a decision. Is this a problem of resistance or is this a problem of compliance? In other words, is this an airway problem or a lung parenchymal problem? I'll continue the discussion in this tutorial on how to investigate the patient with high airway pressures and show you how you come to a final conclusion. The patient with high airway pressures. Part 2. Welcome back. In the previous tutorial, we looked at the problem of airway pressure alarms in the operating room and the ICU. I explained what high airway pressures are. Usually, those pressures are being measured on the machine side of the breathing system. So if airway pressures are being measured as high, it can either be a patient problem or a machine problem. What I mean by that is a problem with the breathing circuit. You must eliminate a circuit problem first to ensure that you do not administer therapies for a patient problem that does not exist. I continue the tutorial with a discussion of airway resistance, how to estimate airway resistance and measure airway resistance using inspiratory pauses, and how to calculate inspiratory resistance. It is important to note that when you look at resistance on the ventilator, whether it is dynamic or static or you calculate it, you are looking at inspiratory resistance. Often the problem is in expiration. In this tutorial, I'm going to initially look at the ways of evaluating expiratory airflow obstruction. First, I will discuss the role that Auto-PEEP plays in the problem of high airway pressures. I will then focus on bronchospasm and airway obstruction and look at flow volume loops and capnography. Finally, I will discuss the other cause of high airway pressure, the stiff, non-compliant lung. First, let's start with the clinical scenario. You're called to the ICU to see Paul. Paul is a 72-year-old male with COPD and he was admitted to the ICU with rapid shallow breathing. He was commenced on volume assist control ventilation with constant flow and the peak pressure alarms went off and his tidal volumes were very low. And we did two things to resolve this. We changed him to a decelerating flow pattern and the peak flow was reduced to 30 litres per minute. His current setting is volume assist control with 470 mils, 24 breaths, a PEEP of 7.5 and his peak pressure is still 35 centimetres of water and his blood pressure is 80/40. Whenever you see a low blood pressure and a high airway pressure, you need to consider either abdominal or thoracic compartment syndrome. By this, I mean that either tissue or expanding masses, including air, are compressing normal tissue and preventing normal homeostatic function. When we look at normal end expiration, the pressures in all of the airways from the mouth to the bronchi to the alveoli to the pleura tend to equalize out at roughly atmospheric pressure. And the airway pressure should be at baseline, either at 0 or at PEEP. Early inspiration is characterized by the generation of negative pressure in the pleura. That drags open the alveoli, generating a relatively negative pressure gradient between the alveoli and the upper airway, and gas flows once the ventilator is triggered along the pressure gradient. At the end of inspiration, the lungs are at tidal volume and all of the pressures have equalized out again. The built-up elastic tension in the thoracic pump will then release into expiration and cause the pleural pressure to rise above 0, thus increasing to thoracic pressure, causing gas to be exhaled. However, in the situation where there is dynamic airway compression or airway obstruction due to all kinds of clinical conditions, including bronchospasm, when expiration occurs, the airways are compressed, but because the exit route for gas is partially or fully obstructed, then not all of the gas is expelled at end expiration. This is particularly problematic if the patient is forced to incur a time cycle breath before exhalation is finished. This, of course, is Auto-PEEP or intrinsic PEEP. Auto-PEEP is positive pressure that is trapped in the lungs at end expiration. It is a problem associated with inadequate expiratory time. The resting lung volume is increased above functional residual capacity. It increases progressively if there is positive pressure ventilation and the obstruction starts acting like a valve. It is frequently associated with airway obstruction, including bronchospasm, and it leads to dynamic hyperinflation of the lungs that makes spontaneous breathing particularly difficult because the patient must generate a much greater negative pleural pressure to trigger the ventilator. And this increases the work of breathing and may lead to exhaustion and progressive hypercarbia and hyperinflation. If you want to look for Auto-PEEP, the first place you can look is at the flow waveform. And this is what it looks like. This is a volume-controlled constant flow breath. The patient's expiratory flow waveform does not come back to baseline before the next breath commences. The red arrow indicates end expiration that occurs at the beginning of inspiration, and that's the orange arrow. Just to remind you that the yellow upward lines are just connectors. These two events occur at precisely the same time. End expiration, beginning inspiration. Now, once you've identified Auto-PEEP on the flow waveform, you need to measure it, but sometimes it doesn't even appear on the flow waveform. It's imperative that you measure Auto-PEEP in any patient who has high airway pressures or is hypotensive. Seeing it on the flow waveform is a great screening tool, but it doesn't either confirm or disconfirm that it's present. In order to measure Auto-PEEP, you need to do a maneuver that is available on all ICU ventilators, the expiratory hold. On this particular machine, we go to the respiratory maneuvers tab. Note that the baseline PEEP here is 5 centimeters of water. We now tap the expiratory pause, and the ventilator will commence the maneuver. The machine then measures the pressure, and the total PEEP is displayed. Helpfully, it then subtracts the extrinsic PEEP from the total PEEP to give us the intrinsic or Auto-PEEP level, in this case 2.3 centimeters of water. Let me demonstrate how this works. When you push the expiratory hold button, the ventilator waits for expiration, and then the inspiratory and expiratory valves close. There is now a column of air between the sensors on the expiratory limb of the machine and the alveoli. This is similar to an inspiratory hold. The pressures that one sees on the screen are being measured by sensors in the machine, not in the airway, so the gas flow must stop to measure any static pressure or resistance. In this case, the pressure that is being measured will rise above baseline, that's atmospheric pressure or PEEP, and rest at a higher pressure level. That is the total PEEP level. I'm just going to show you a clinical scenario. This is a patient that we know has Auto-PEEP, and when you look at the flow waveform, it's not that impressive. Yeah, the expiratory flow doesn't quite go back up to baseline, but it's not a huge gap. And you would think, well, this must equate to not an awful lot of Auto-PEEP. But in fact, when we actually did a Auto-PEEP maneuver on this patient had an intrinsic PEEP of 7.1. She was on 5 of PEEP, and the total PEEP was 12. And this actually got worse. We turned off the PEEP, and subsequently her intrinsic PEEP was 9, 12, and kind of stayed there. So you really do need to do this maneuver to ensure that you know how much Auto-PEEP is present. And if there's a lot of extrinsic PEEP and you can't control it by other maneuvers, get rid of the extrinsic PEEP. Now let's move on. If you're serious about looking for airflow resistance problems, you must look at the flow volume loop. The great thing about the flow volume loop is that it will show you flow resistance on inspiration and on expiration. And you recall when you look at the dynamic resistance on the ventilator and when you calculate resistance or measure resistance, it's almost always on inspiration. It is possible to do this on expiration, but it's not done by the ventilator and it requires some more mathematics. You can just eyeball the flow volume loop. And if you see this pattern, this scooped out pattern in expiration, you know that this patient has airflow resistance. So this is the picture that you're looking for with someone, for example, who has bronchospasm. This is the other flow volume loop that you should be looking for in a patient that you suspect has airway obstruction. And you can see in this picture when I show you the standard flow volume loop that you would expect for this patient, that the flow is low and the volume is low. And it's going on in inspiration and expiration. And this is the typical situation you see where the endotracheal tube is either kinked or it's being occluded by a patient biting it, or for example, a bite block has been placed during surgery, for example, ENT surgery. And if you see this picture, you need to look at your endotracheal tube really carefully and unobstructed. This is an example of a patient who is biting on his or her endotracheal tube. Take note of the really high airway resistance. The flow volume curve demonstrates airway obstruction in inspiration and on expiration. And this is another patient with airflow resistance in both inspiration and expiration. You can see that big expiratory scoop. We were unclear why the resistance was so high. The inspiratory resistance was 43 centimeters of water per liter per second. So we performed a bronchoscopy. And this is after we pulled the endotracheal tube back. You can see that the tip of the tube was at the carina and it was partially obstructed. When it was withdrawn, the inspiratory component of the increased resistance disappeared from the volume pressure curve. But the patient still had a problem on the expiratory limb, and this patient had really poor compliance and poor resistance. I want you to focus on the volume pressure curve. You can see that scooped out expiratory flow waveform. This is indicative of airway obstruction, and this patient became very, very wheezy once we diuresed them, and we gave them a lot of bronchodilators, and it eventually resolved. It's important to understand, though, that not all airway compression is bronchospasm. Now, a way of looking at airway compression or airway obstruction is to categorize it. For example, it may be a problem in the lumen, an inhaled foreign object, a surgical throat pack, a piece of suction tubing that got stuck there, all kinds of stuff. And that will obstruct the airway without the airway itself being diseased. It may be in the wall. Now, this can happen in patients with bronchogenic carcinoma or very large lymph nodes, or it can happen because there is inflammation and the walls are boggy and edematous and the mucosa is wet and soggy and there's lots of secretions, and those secretions may be blocking up medium-sized airways. There may not be bronchospasm at all here, it's just that there's so much gunk in the airways, the airway resistance is high, and we see this all the time in the ICU, and it's the first thing you should really think about if your airway resistance is high, or if the patient's got a very jittery looking picture in the flow volume loop, or there is abnormalities in both the inspiration and expiration of the flow volume loop that doesn't fit the patterns that I've already shown you. The other problems may be outside the wall. For example, the patient may have dynamic airway collapse. They may have a large heart that's sitting on the left lower lobe bronchus and compressing it. The patient may have mediastinal tumors, and even densely consolidated lung tissue may compress medium-sized airways and increase airway resistance. The final method of evaluating expiratory airflow obstruction is to look at the capnograph. End-tidal CO2 measurement provides you with excellent information about the status of the airway, the quality of ventilation, and the presence of a cardiac output. The graphic representation of CO2 release from the lungs is a tremendous diagnostic tool, and I have a whole tutorial on that you can find on my blog or on YouTube. Basically, this is a capnograph, and what we have on the y-axis is the CO2 that's being measured as it comes out of the patient. And this is the normal trace. I've colored the active part of the trace in orange, and it starts at baseline where exhalation begins. The exhalation graph sweeps upwards, usually straight up, and curves around and then stops. And at that point, if you're measuring end-tidal CO2, that's the point you measure at end exhalation. And this is a normal capnograph. When you see a picture that looks like this, where there's a really gently upward curving waveform, this is abnormal, and it's caused by lung units emptying slowly due to dynamic airway compression, often associated with airway resistance in exhalation, commonly seen in COPD, and it's caused by slow emptying of partially obstructed airways. In this picture, I have a graph on the right-hand side of the screen and a series of airways on the left-hand side of the screen. And I'm going to draw a capnograph now on the right-hand side. And you'll note that there are different colors along that curve, starting with the red one, where the airway is open and there's no obstruction, and then the airways become progressively more obstructed as we go towards the crest of the waveform. And I'll show you what happens with the gas. The lung units with the shortest time constants are at the top and they empty quickly, and the ones with the longest time constants are at the bottom and they empty slowly. And that's why you get this curve in COPD. Now let's move on to a discussion of respiratory system compliance. Compliance refers to how easy it is to expand the lung by applying pressure. If the lungs expand easily, they are compliant. If not, they are uncompliant, non-compliant, or have high elasticity. These are all terms that are used to describe stiff lungs. Compliance refers to the rate of change of tidal volume versus airway pressure. The measurement is in mils per centimeter of water. Because it includes the stretchability of the lung and the chest wall, the correct term is total respiratory system compliance, and normally that is in excess of 50 mils per centimeter of water. If you're looking at airway pressures, in patients with low total respiratory system compliance, the peak and the plateau pressures are both very high, and there is often little difference between the two. Maureen is 62 years old, admitted 2 days ago with rapid shallow breathing. Her PF ratio is 150. That's the PaO2 divided by the FiO2, and this is moderate to severe hypoxemia. She was trialed with high flow oxygen therapy. That failed. She was given CPAP. That failed. And her chest x-ray demonstrated bilateral consolidation, so she was intubated and put on volume assist control ventilation with a tidal volume of 350 mils and a PEEP of 5. One of the first things that's worth looking at on a patient with hypoxic respiratory failure is the volume pressure curve. Volume is on the y-axis and the airway pressure is on the x-axis. Maureen's initial volume pressure curve looked like this. But 3 hours later, it had deteriorated to this. Note that it takes more pressure to achieve the same target tidal volume. In other words, total respiratory system compliance has fallen. This is the vent screen of a patient like Maureen who has low respiratory system compliance. And we can zoom in on the volume pressure curve, and you can see in this patient's case, there is a stunning amount of pressure required just to get the lungs open, and then they suddenly open and the patient gets a tidal volume. You will note that above this screen, there is a number displayed known as the dynamic compliance. And this causes endless confusion because compliance is a confusing topic. The ventilator measures dynamic compliance from breath to breath during active breathing. That volume pressure curve is dynamic, and the information that you're seeing in that numbers bar is the compliance for that particular breath. It reflects the elasticity of the lung and the chest wall, that's the total respiratory system compliance, but also the airway resistance. So someone with very high airway resistance may have a very flat volume pressure curve. The calculation in real time uses peak inspiratory pressure. So the calculation for dynamic compliance is tidal volume divided by peak inspiratory pressure minus PEEP. The static compliance assesses the lung's ability to expand when there is no airflow. It reflects the elasticity of the lung and chest wall, that's the total respiratory system compliance, and eliminates the resistance. The measurement requires an inspiratory hold, and it uses the plateau pressure. So the calculation for static compliance is tidal volume divided by plateau pressure minus PEEP. And when we are looking at parenchymal lung disease, we are interested in static compliance. Static compliance is measured during an inspiratory hold. So let's go ahead and do an inspiratory hold maneuver. You can see that on the inspiratory hold, the ventilator measures plateau pressure and static compliance. That plateau pressure will drop off a little bit as you hold it because of air being removed from the lungs going into the bloodstream. Inspiratory holds can be performed in volume or pressure control. They both give you a plateau pressure and a static compliance. But if you use volume control with an inspiratory hold, you can also obtain inspiratory resistance. So when I'm doing this, I'll usually switch the patient to volume assist control and put on a hold. But regardless of whether you do it in volume control or pressure control, there is a problem with measuring static compliance in this way. Maureen has a tidal volume of 350 mils and her plateau pressure is 30 centimeters of water. Her PEEP is 5 centimeters of water. How do we actually calculate out the total respiratory system compliance? Well, let's work the problem. The compliance is the tidal volume divided by the driving pressure. The driving pressure is the plateau pressure minus the total PEEP. The driving pressure is the pressure that's used to measure compliance. It's the difference between the plateau pressure and the PEEP, but that does not account for intrinsic PEEP or Auto-PEEP. The presence of Auto-PEEP results in an artificially reduced compliance because the driving pressure is lower than one believes. In order to calculate the total PEEP, you must perform an expiratory hold maneuver to measure Auto-PEEP. So let's rework the problem. Tidal volume divided by total PEEP. Total PEEP is the PEEP plus the Auto-PEEP. And in Maureen's case, we do an expiratory hold maneuver, and her PEEP is 5 and her Auto-PEEP is 7. So the total PEEP is 12. It's much higher than we thought. That means that the driving pressure is much lower than we thought. So what we have is a tidal volume of 350 mils, and we now know that the inspiratory pressure, the plateau pressure, was 30 minus the Auto-PEEP, that's 18, and that equals 20 mils per centimeter of water. Now this is very low. However, it's very important to recognize that all we have described here is a low total respiratory system compliance. It is non-diagnostic. There are many reasons why the total respiratory system compliance may be very low. In this case, it is possible that the lungs are non-compliant because they're being overstretched. That is because the total PEEP is very high. In this situation, I will reduce the respiratory rate to see what happens with longer expiratory time. Does the compliance improve with lower intrinsic PEEP? And if your patient has low total respiratory system compliance, there are two components to that respiratory system, the lungs and the chest wall. Low compliance results from an increase in the tendency of the lungs to collapse inwards and a reduction in the tendency for the chest wall to spring outwards. Let's look at low lung compliance. Now this is either caused by widespread collapse of lung tissue or atelectasis that may be either compressive or absorptive or both, or the filling of lung tissue with inflammatory exudate, which is consolidation, or fluid such as pulmonary edema. Pulmonary edema may be cardiogenic, neurogenic due to sepsis or capillary leak when it's known as ARDS, or due to airway obstruction such as post-obstructive pulmonary edema. Lungs may be chronically non-compliant where there is pulmonary fibrosis. The other cause of a reduction in total respiratory system compliance involves the chest wall and its inability to spring outwards. It is imperative that if you see high airway pressures that you consider everything that I will show you in this cartoon. First, you need to consider intrathoracic compression, which is a chest compartment syndrome. I have previously described how very high levels of Auto-PEEP can be devastating because it causes problems within the lung parenchyma. A similar situation can occur with excessive PEEP. Outside, between the lung parenchyma and the chest wall, fluid, blood, or air can accumulate in the pleural space and you get pleural effusions, pneumothorax, or hemothorax, and these cause lung compression. The other problem is extrathoracic compression. Remember that the chest wall involves what we consider to be the thorax and the chest cage and the abdominal surface of the diaphragm. Anything that restricts chest movement may prevent lung expansion and increase airway pressures. These include morbid obesity, poor patient positioning, chest braces, tight dressings, and a particular problem known as abdominal compartment syndrome. Intra-abdominal pressure is usually lower than 10 millimeters of mercury. After all, the abdomen is usually very soft. However, if for any reason the abdominal contents expand, and this may be, for example, a problem with the bowel, gas trapped by ileus or severe constipation, bowel edema due to over-resuscitation or capillary leaks, surgical packs, pneumoperitoneum, any of these increase intra-abdominal pressure and may compress the diaphragm and the lungs. Intra-abdominal pressure is typically measured by transducing the pressure within the bladder. If it is in excess of 12 millimeters of mercury, there is intra-abdominal hypertension. The presence of intra-abdominal pressure of more than 20 millimeters of mercury and low total respiratory system compliance is abdominal compartment syndrome. You can do nothing with the mechanical ventilator to resolve this problem. This patient's abdomen needs to be decompressed either medically or surgically or both. Let's review this tutorial. In this tutorial, we discussed the patient with high airway pressures, how to assess Auto-PEEP with bronchospasm, we looked at the flow volume loops, and then we looked at capnography. Finally, we looked at the problem of high airway pressures and low total respiratory system compliance, and I explained that this means that the patient may have low lung compliance or low chest wall compliance or both, and low chest wall compliance may be a problem inside the thorax or outside the thorax, and one particular case of low chest wall compliance is caused by the abdominal compartment syndrome. So that was the patient with high airway pressures. If you enjoyed this and you're finding these tutorials useful, please give me some likes, subscribe to the channel, and follow me at ccmtutorials.org.